Hello and welcome to the topic Skin Manifestations in Systemic Diseases in the Dermatology module. By the end of this topic, you should be able to define skin manifestations in systemic diseases, explain the pathophysiology of skin manifestations in systemic diseases, outline the causes and classifications of these skin manifestations, describe the skin manifestations in systemic diseases, outline the investigations, discuss the principles of management, and finally discuss the complications and prognosis of these manifestations. Let's get started. So, skin manifestations of systemic disease can be wide, varied, specific, and non-specific. Let's begin with generalized pruritus, which is an unpleasant sensation that provokes the desire to scratch, while erythema nodosum is an acute nodular and erythematous eruption that is usually limited to the extensor aspect of the lower limbs, and it's more commonly seen in women in their 20s to 40s. Chronic liver disease also manifests with skin findings, as the dysfunction of liver lead to accumulation of certain substances that eventually cause cutaneous manifestations. These findings are common but non-specific, as they are also seen in patients without liver diseases and generally do not indicate about a specific underlying hepatic disorder. The presence of a constellation of signs and symptoms is more useful in pointing towards an underlying hepatobiliary condition. Connective tissue diseases such as cutaneous lupus erythematosus, dermatomyositis, and scleroderma have significant cutaneous manifestations that may exhibit widespread systemic dysfunction. Skin is often the presenting sign, although connective tissue diseases involve multiple systems. Paraneoplastic dermatosis are a group of skin disorders that have strong associations with internal malignancies. However, cutaneous findings result from entry of tumor cells into the skin and are not considered paraneoplastic dermatosis. So these are the skin manifestations that we will be discussing in this topic. Now, a little bit about the function of the skin. The skin is a reflection of internal processes seen in many diseases. The skin as an organ goes beyond its protective and barrier functions, as it provides clues for the identification of some systemic diseases. The skin is easily accessible to be examined by doctors. With trained eyes and biopsies, the skin can reveal specific or non-specific alterations on histopathology, which points to a certain disease. The sensation of pruritus is transmitted through slow-conducting unmyelinated C polymodal and possibly type A delta nociceptive neurons with free nerve endings, which are sensitive to pruritogenic substances. Histamine, neuropeptide substance P, serotonin, bradykinin, proteases, and endothelin activate these nerves and causes pruritus. Erythema nodosum is a delayed hypersensitivity reaction to a variety of circulating antigens. When there's chronic liver disease, the liver is unable to remove excess estrogen, and this leads to arteriolar smooth muscle relaxation. And this happens due to excessive estrogen. This causes formation of spider nevi and palmaerythema. Liver insufficiency also causes cholestasis and eventual pruritus. In SLE, there is an autoimmune response which produces antibodies that bind to soluble immune complexes that get deposited under the skin. This leads to inflammation, discoid rash, subacute cutaneous lupus, and malar rash. Systemic sclerosis, including vasculopathy, and multi-organ interstitial fibrosis is seen in scleroderma. This causes endothelial damage, dermal fibrosis, and damaged vasculature. Dermal fibrosis leads to thickening of facial skin, causing mask faces seen in scleroderma. Inflammatory scarring also causes calcium to be deposited under skin, leading to calcinosis cutis. Abnormal vasculature in scleroderma leads to dilatation of arterioles and thus telangiectasia. Vasospasms cause Raynaud's phenomenon. Dermatomyositis is caused by triggers that increase dermatomyositis-associated antibodies which bind to DNA or RNA muscles. This leads to an inflammatory response and capillary necrosis, which present as Gottron papules or heliotrope rash. Regarding internal malignancies, it was found that the tumor and cutaneous changes develop over a similar period of time and follow a parallel course. A specific type of neoplasia also occurs with paraneoplasia. The dermatosis is rare in the general population and may be recalcitrant to treatment. Additionally, there is a high frequency of associated between skin reaction and tumor. Causes of generalized pruritus include hematology disorders such as iron deficiency anemia, myeloproliferative disorders, monoclonal gammopathy, and multiple myeloma, as well as lymphoma. It can be due to renal disorders because of uremia and liver disorder which is associated with cholestasis. Endocrine disorders including hyperthyroidism and hypothyroidism have been found to cause generalized pruritus. Erythema nodosum is caused by infections such as streptococci, tuberculosis, and brucellosis. Systemic diseases including sarcoidosis, inflammatory bowel disease, Behçet's, and systemic lupus erythematosus. Other causes include malignancies, lymphoma, pregnancy, and drugs. Examples of drugs such as oral contraceptives, sulfonamides, penicillins, antipyretics, Montelukast, hepatitis B vaccination, and omeprazole. For chronic liver disease, on the other hand, liver insufficiency remains the main cause of skin manifestations, while connective tissue disease causes deposition of excessive immune complexes, which eventually leads to the inflammatory response that manifests as skin manifestations. Generalized pruritus is classified into neurogenic, psychogenic, neuropathic, and pruritoceptive. For neurogenic, it is generated in the central nervous system in response to pruritogens but without any evidence of neural pathology, while psychogenic pruritus is caused by a psychological disorder. Neuropathic pruritus is a result of neuronal pathology along the afferent pathway, while pruritoceptive pruritus is generated in the skin, usually by inflammation or other visible pathological processes involving the skin. Acanthosis nigricans is associated with intra-abdominal adenocarcinoma, lung carcinoma, and lymphoreticular malignancies, while acrokeratosis paraneoplastica, also known as Behçet's syndrome, is seen in squamous cell carcinoma of upper aerodigestive tract. Erythema gyratum repens is seen in lung carcinoma, while glucagonoma manifests with necrolytic migratory erythema. Sweet syndrome and pyoderma gangrenosum is associated with leukemia, lymphoma, and multiple myeloma, while paraneoplastic pemphigus is seen in hematological malignancies and thymoma. So individuals with generalized pruritus will complain of course, itchiness. Those with erythema nodosum might experience fever, arthralgia, and painful rash on the skin. Chronic liver disease may present with jaundice, itchiness, and dilated veins on the chest and abdomen. SLE presents with butterfly rash on the cheek, annular lesions, and erythematous papule or a small plaque with slight scaling. Patients with scleroderma will complain of tightness and thickening on the skin with red marks and bluish discoloration of the fingers. Dermatomyositis present with eye swelling, while those with internal malignancies will experience constitutional symptoms and ill-defined hyperpigmentation of the skin. Examination of the skin manifestations reveal different findings which points to specific underlying disease. Renal pruritus examination reveals diffuse cirrhosis, signs of peripheral neuropathy, and uremia, while cholestatic pruritus will be associated with jaundice, spider angiomata, Dupuytren's contractures, white nails or leukonychia, gynecomastia, xanthelasma, splenomegaly, and ascites. Patients with hypothyroidism will have brittle nails, dry and coarse skin, while in hyperthyroidism it's associated with fever, tachycardia, exophthalmos, and atrial fibrillation. Iron deficiency anemia presents with pallor, glossitis, and angular cheilitis. Individuals with polycythemia vera have ruddy complexion around the lips, cheeks, nose, and ears, while erythema nodosum might have lymphadenopathy. Individuals with SLE will have malaerythema, psoriasiform rash affecting arms and chest, well-demarcated plaques with adherent scale which leads to alopecia, while dermatomyositis will present with heliotropic rash with periorbital edema, Gottron's papules, and photodistribution of the rash. Examinations of individuals with scleroderma will show Raynaud's phenomenon, telangiectasia, and digital infarcts. Generally, these investigations can be done, which include microscopic examination, culture and sensitivity of skin scrapings, skin biopsy, patch testing, and full blood count. Specific lab tests are done for different skin features to diagnose underlying disease. For generalized pruritus, investigations include systems review, pruritus screen, blood urea and serum electrolytes, liver function test, thyroid function test, iron studies, serum protein electrophoresis, and blood sugar profile. While for erythema nodosum, it requires chest X-ray to rule out sarcoidosis, anti-streptolysin O titer, and throat swabs, as well as beta HCG levels. Chronic liver disease require liver function tests to be diagnosed. Other tests include CT scans and a full blood count. Connective tissue disease is evaluated by the presence of antibodies such as anti-nuclear antibodies, anti-double-stranded DNAs, lupus anticoagulant, and anti-cardiolipin antibody. Other tests include liver function tests, a renal profile, and urine analysis. To evaluate internal malignancies, relevant tumor markers levels can be investigated. The treatment for skin manifestations of systemic disease varies depending on its underlying cause. Without eradication of underlying systemic disease, treatment is often palliative. For generalized pruritus, it is important to exclude and treat primary dermatologic disorders, exclude commencement of new medications, and stop or substitute where appropriate. If cirrhosis is present, recommend a soap substitute and regular emollients such as sorbolin and 10% glycerin, symptomatic mentholated cream including 1% menthol in aqueous cream as shown to improve pruritus. In most patients, erythema nodosum is a self-limiting disease and requires only symptomatic relief using non-steroidal anti-inflammatory drugs, cool wet compressions, elevation, and bed rest. Cholestyramine is the mainstay of therapy for pruritus of liver disease. To avoid compromising GI absorption, care should be taken to avoid co-administration of this organic anion binder with any other medication. There is no specific treatment for spider nevi and palmaerythema besides treating the liver insufficiency itself. SLE is treated with oral dapsone, antimalarial or systemic immunosuppressant such as prednisolone and cyclosporin. Scleroderma is managed with imatinib, cold avoidance for Raynaud syndrome, and calcium channel blockers for calcinosis cutis. Management of cutaneous disease of dermatomyositis include use of topical corticosteroids, topical tacrolimus, antimalarials, and immunosuppressants. When there is muscle or systemic involvement, systemic corticosteroids such as prednisolone, high dose with slow tapering dose with other immunosuppressive drugs should be given. For severe cases, consider intravenous immunoglobulin and avoid excessive sun exposure. Treatment of malignancy is essential for internal malignancies. Chronic generalized pruritus can lead to lichen simplex chronic, prurigo nodules, and excoriations, which are susceptible to infections. Chronic connective tissue disease is associated with poor quality of life. So let's summarize. Skin manifestations in systemic diseases are a result of either inflammatory response, deposition of immune complexes, or excessive substances under the skin or neurogenic cause. In generalized pruritus, the nerve endings are sensitive to pruritogenic substances released in various medical conditions, while erythema nodosum is a delayed hypersensitivity reaction to a variety of circulating antigens. Chronic liver disease leading to liver insufficiency cause liver to be unable to remove estrogen, and these excessive estrogen relaxes arteriolar smooth muscles, leading to formation of spider nevi and palmaerythema. Connective tissue disease are caused by autoimmune response producing excessive antibodies that bind to form immune complexes, which gets deposited and damages vasculature. Causes of generalized pruritus include hematologic disorders, renal disorders, liver disorder, and endocrine disorders. Erythema nodosum is caused by infections, systemic diseases, malignancy, lymphoma, and drugs. Lab investigations include full blood count, liver function test, renal profile, autoimmune serology, and thyroid function test. The treatment for skin manifestations of systemic disease varies depending on the underlying etiology. Without eradication of the underlying systemic disease, treatment is often palliative at best. We have come to the end of this topic. Thank you.